Do you want to do like one more housekeeping,
Okay, so if anybody's joining us on the chat or on Facebook, you will get credit for it, whether you join us on Zoom or whether you just opened up your phone and joined us on Facebook Live. If you're joining us on Facebook Live, you do need to email me. I will put my email inside the chat. I'll put my cell phone number in the chat. If for whatever reason you are needing to contact me, I'm always here at the office. But I just want to make sure you're getting your CE credit, and then of course your course evaluation. Your feedback is important to us, so we would really appreciate if you guys could return those over to us. This is a TISHA approved conference, which is ASHA approved, but you need to hold on to your certificate and submit that over to ASHA. Let's see, getting a few more text messages. No pre-registration was required. If you guys want to share the link, please do so. The more people that can join and come and listen to how we're going to improve care in the nursing homes is welcome to join. All right. So we have about 1 minute, and then we'll get some introductions and get started. So thank you guys for joining with us and being patient. Okay, great. We have somebody who's helping us on the chat. So if you're sending us a chat, please ask questions on there. We'll have somebody that will be able to make sure those questions get filtered over to us. Also, you're able to unmute yourself at any time. We'd love to hear you.
ready?
All right, well, it is 4 o'clock.
But it's 5 o'clock somewhere, Stephanie.
It's 5 o'clock somewhere. We do have, for those of you
In 3 of our states, it's 5 o'clock already, so you guys are lucky. Are we ready?
Yeah.
Well, we want to welcome you guys, definitely welcome you here to the Drink and Learn. It's always better if you can learn something if you're drinking, right, Stephanie? Whether you're having a mocktail like Stephanie and I, or you're having an actual cocktail or your favorite drink of choice, we're excited that we want you to come in, sit back, relax. We're going to have this as a collegial discussion. Stephanie and I are super happy to have this opportunity to discuss with all of you, all of our colleagues out there, what we've learned about PDPM, better known as the patient-driven payment model. Gone are those old days of flatline, providing as much therapy as you can to every single patient. Medicare said, we're ready for a change. We want to stop incentivizing how much therapy is being provided and require providers to give the right amount of therapy depending on how medically complex the patient is. And we're going to get to that in a minute. So I'm Piper, and this is Stephanie, and we are SLPs and owners and managers of Professional Imaging and Midwest Dysphagia Consultants. We're located currently in 4 states. That's Texas, Ohio, Indiana, and Kentucky. So if you're here from all over the country, we're super excited that you joined us. We do the mobile modified barium swallow studies, and really our sole purpose is to take what we're doing as part of your care team who are doing the instrumental evaluations and make it valuable to the entire care team. So not only does the patient win, but the whole team wins, including the nursing homes who are also our clients and invite us to come in to be a part of your team. And we even have a super big surprise for you guys at the end. We're looking past not only PDPM or this new patient-driven payment model, but we're going to be giving you a little information about what's happening with Medicare and how they're approaching these outcome models as well. So not only do you have to provide the right amount of therapy, but you've got to actually get the patient better. So at the end, we'll stop a little early before 6 o'clock, and we'll have Evelyn and Gabby from Mobility. We're super excited to share this device with you. It's a biofeedback device that can fit in your pocket. So if you guys are familiar with other huge machines where you're trying to measure pharyngeal squeeze and it's not maybe affordable or accessible for your delivery model where we're all in long-term care, practical healthcare, there's less resources, more people, then this may be an option for you guys, and we're going to be excited to have them do a presentation for you and focus not on past just the evaluation, past just the coding for Medicare, communicating medical complexity, but into the treatment mode as well. And just to make this a little more fun, I've been watching a lot of Real Housewives, Bravo TV, because of course the pandemic has kept us at home a lot more than Stephanie and I have ever been in our houses before. So to make it a little more fun, we've chosen kind of a word of the day, and it's going to be medical complexity.
It's actually 2 words.
Well, it's 2 words. 2 words of the day, right? So whenever you hear these words, we want you to take a drink of your favorite mocktail, cocktail that you're joining us with, and hopefully that'll make it a little more fun and heighten your awareness to this word. And I want to ask you all, what do we mean by medical complexity? Are y'all hearing this at the facility level? This is the foundation of the patient-driven payment model, or the PDPM system. Instead of therapy, how much therapy, like the prospective payment system, we're into medical complexity. How would you define medical complexity? Does anybody know what that means, or how you would view that?
Isn't that all the diagnoses they get that they score on the MDS to figure out the reimbursement?
Absolutely. Those are all the diagnoses that are contributing to a patient having or needing a certain level of care. So now they're really focusing on what does this particular patient have that makes them more medically complex than the next patient. Why do you think all the patients that have dysphagia fall in this category of medical complexity? Anybody want to take a stab at that? Is dysphagia a primary diagnosis? Do people typically come in with just dysphagia?
No.
No, that's exactly right. It's an R-code diagnosis or a secondary diagnosis. So when you're looking at patients who have stroke, Parkinson's, Alzheimer's, any of these other primary medical diagnoses, and we're identifying dysphagia, the good news for us as therapists is we're adding a diagnosis that Medicare recognizes as increasing that level of medical complexity. So just the fact that we're evaluating patients for dysphagia puts us in a good position to be able to help the care team communicate that. So what makes you, the SLP, so invaluable as part of the care team under this patient-driven payment model is the fact that you are the specialist who can evaluate and manage dysphagia. And you can combine that with all of the other knowledge that you have about cognitive issues, patients that have other neurological involvement, and you can heighten that medical complexity where it's appropriate. So we're hoping to empower you with information that you need to provide you with not only job security by identifying these patients that are more medically complex, but being able to document and communicate that correctly to Medicare and to the care team, because that way you're able to generate the right amount of resources to care for those patients. Then the patient, not only does the patient win because they get the right amount of care, but the care team and the facility also win because there's enough resources to take care of that patient at the right level. So I want you all to sit back and relax, get your cocktails out, and let's get this party started. All right, so here's the big objectives that I want you to focus on today. I want you to recognize how prolific swallowing problems are in stiff patients. Understand business basics. One thing that I learned as I was starting my mobile medical practice is I'm a great clinician. I really understand dysphagia evaluation, consults, treatment, and management for dysphagia, but I didn't quite have a handle on the business basics that make you successful as a business. I think all of us are a little more aware of some of our business aspects since the hit of the pandemic, and we've noticed that we've had to make a lot of changes and our employers have had to make changes. So I think understanding these business basics will help you tie everything together so that everybody in the care team, from administration to the building owners, to the rehab owners, to the patients, win. Value of identifying medically complex patients under PDPM, identify and communicate medical complexity, maintain a happy marriage between business and patient care. So I hope by the end of this course, you feel empowered that you can take the knowledge that we've given you, that it's practical, and you can apply it Monday morning when you walk into a facility. So how prolific is dysphagia among SNF patients? Do you guys know how many patients are reportedly having dysphagia in skilled nursing facilities by the National Swallowing Foundation? Anybody want to take a stab at that?
About
This
7.
is a guess, but I would guess maybe 25%.
How many?
Just a guess, 20%, 25%.
Okay, great. Does anybody else have another guess?
I think it's about 70%.
Wow, that is astounding. That is an astounding number, right? I mean, if our chances of getting COVID and having a bad outcome were 70%, we would be highly concerned. Thank goodness we're learning more, and it's much lower than that. But let's see with the National Swallowing Foundation. So we're going to figure out if it's between 25 and 70%. Here's the number, boom. 68% of nursing home patients reportedly have dysphagia, or it can be as high as 68%. Why do you guys think this number is so high? I mean, that is astounding to me. That's 6 or 7 patients out of every 10 that are admitted to a nursing facility.
Cognitive dysphagia. If you have a memory care unit, I mean, there's, doesn't surprise me too much, I guess.
And there,
Everybody take a sip. Medically complex patients, right? We are getting patients, and the most amazing thing is that a lot of these patients have silent symptoms of dysphagia. So they're admitted for their primary diagnosis. They're not going to be able to return home because physically they can't take care of themselves, or cognitively they can't take care of themselves. But there's an underlying silent illness that's occurring that we recognize as the trained professional in the building. So if we don't identify it, it typically doesn't get identified. So the reason that these patients are so at risk at having dysphagia is your small muscle groups get in diffuse atrophy in 2 weeks. So if you're laying in a hospital bed for 3 months and then you're admitted to a skilled nursing facility, you have physical weakness, the chances of it affecting your muscles of swallowing are very high, because all of those primary diagnoses are what lead to a patient having a sequela of dysphagia. Great job, you guys. So if you were in Vegas and I told you your odds are 68%, you're going to hit the jackpot, would you play that game? Anyone?
I
What
would.
if I told you there were 25%? Would you play that $100 blackjack hand?
Seems like
$150
that.
blackjack hand? But what if I told you they were almost 70%, that if you invest $100, you're gonna make something on that table? You would probably play that hand. I would play that hand. Would you play that hand, Stephanie? I don't think we ever win when we go to Vegas, do we? We take the team once a year, but our odds are never that good. So knowing that the odds are very high that patients can have dysphagia, this is going to drive what you're going to do when patients are admitted, because the chances of the patient that's coming in on the skilled hall having dysphagia are extremely high. So you need to be included from the very beginning, and we're going to tell you how to do that. So if you have a 100-bed facility and you have 68% of those 100 patients having dysphagia, and we realize that not, this is just simple math, right? We realize that not all of those patients would be skilled unless you're just a skilled facility. But let's say you have 68% of those patients that have dysphagia. How many of those patients would qualify for your care?
68.
Great. So if 68 patients are appropriate, let's say your number's lower because your facility doesn't have as many skilled beds, you've got to go in there and you've got to find all of the patients that potentially qualify, because this is how you're going to communicate to Medicare that they need an increased level of care. So 68% or as high as 68% could need you. Now we know that there, if you had 68 patients, you would need 3 or 4 therapists coming in, speech therapists. And I'll tell you, the speech therapists who are starting to recognize how prolific these problems are starting to build really big caseloads in their facilities, treating and managing dysphagia. And that is because we are so needed in this population. What happens is they're trying to get the patient better. And one of the top 15 reasons that patients are readmitted to the hospital is aspiration pneumonia. So then they're sending the patient back out. They left us out in the first trial. And now we're realizing we've got to start getting back involved sooner before the patient has another occurrence that puts them in the hospital. So let's shift into a little bit of business basics. I think we have a good understanding of how many patients or how high that number of patients is that are being admitted into nursing homes that are needing our care. But we also need to understand why or how the rehab and the administration team is now viewing therapy. Before, for the prospective payment system, it was how much therapy did you provide? They were looking to the therapist to say how much therapy, and they looked backwards and they gave you a certain amount of money. Now we're looking at the patient and they're needing the care team to say, how complex is this patient and how much therapy do they need? Because Medicare wanted to see more peaks and valleys with care being administered appropriately, depending on how much care that patient might need or how medically complex, there's your word, this patient can be. So I think it's important that we shift perspectives and get out of just our role as the clinician and start looking at how the business functions so we can understand where we fit in that value cycle. So let's just talk about your household related to a skilled nursing facility. So how do you know, or what is your cue that you have money coming in your own home? You get your paycheck. Well, how does a skilled nursing facility have revenue or money coming in? They're typically paid in a skilled stay by insurance, like such as Medicare or managed care. If they're more in a long-term stay, they may be paid by Medicaid or private pay. So everybody in their households, or let me ask you this, if your paycheck suddenly was reduced, which I think a lot of us worried or struggled with that during the pandemic, what happens to your concern for money coming in? You start getting a little worried, start figuring out, okay, what can I cut from the budget? Like what has to go? Most of us do, right? We start saying, oh my gosh, you know, these things aren't working. I'm making less money. They've cut my hours back. Well, it's the same for a skilled nursing facility. If they're making less money from Medicare, less money from managed care, less money from the insurance, they're not admitting as many patients, especially during COVID. Some facilities stopped admitting patients. They suddenly become concerned about the amount of money that they have coming in. Whenever they change a payment model or payment structure, they start figuring out, okay, we need to learn what the system is and how we're going to generate revenue to care for these patients. Does anybody have any questions about that? No? Okay, so then once you know what money you have going in, you have to be aware of what money is going out. So I put just a slide together to show a little comparison about maybe the things that you would have budgeted into your household, your expenses, and then what the nursing home would have budgeted in for their expenses. So you might have a home mortgage or rent. They may have a commercial loan on the building. You have utilities for yourself, your family, gas, electric. They have it for all the staff and patients. You have cell phone and internet. They have EHR, phones, tablets, computers. You have food. They have food, and not only food, but also service staff to prepare the food for the patients. And then, of course, all the modified food choices that we have to offer to the patients, particularly with dysphagia. You have a car payment, they have the van transportation that they have to organize, plus the person to drive the van. You might have a student loan, they have liability insurance. You have insurance, they have liability insurance. You have childcare, they have support staff, rehab staff, PAs, MDs, administration, everybody there taking care of the patients. And then a new one during the pandemic was PPE. For instance, my medical practice, we suddenly realized we needed PPE, and we started trying to figure out where we were going to get it as quickly as possible last March, like every other facility. And suddenly we realized, okay, we're going to have to budget an extra $8,000 suddenly to get enough PPE to protect our staff and our patients. So that was an unexpected expense, and those are times when businesses start getting a little more concerned, just like you would at your household. If suddenly you have your dishwasher go out and you have to go buy a new dishwasher, you start figuring out, okay, where does this fit in the budget? Do I need to work a little more? Do I need to pick up a side gig? What do I need to do to make that work? Well, it's the same for a business. They start figuring out what are the things we're going to have to sacrifice to take on these added expenses. So understanding the math and making it super simple, if you have an income or revenue of $100 and you have expenses of $120, what does that look like? You have a loss, right? So you have a minus $20. If you have an income of $120 and you only have expenses of $100, how does that look for you at your household or the nursing facility? Now you are in the green, you have a profit, right? You have a positive amount of money. So you feel good about the budget. So depending on where you fall in that revenue expense cycle, it can change how you approach how you're going to manage your household, or it can change how the business is going to approach managing their patients or their rehab staff or their therapy staff. So just like your household, skilled nursing facilities cannot lose. What would happen if they lose too much money? And we've seen this a little too frequently this year.
Sell the building or do contract therapy.
Exactly. They start figuring out, what do we have to cut, right? What's got to go? We've got to downsize. We need to outsource therapy. We're not going to be able to have in-house. Or the worst case scenario is that the facility closes or they're sold. And then of course that affects the patients who are there, that affects you for your job security. So at the end of the day, the business has to win, because that protects your job security, and the patient has to win because the better the facility has as a reputation, the more patients are going to be clamoring to get in their door. So everybody has to work together in a symbiotic relationship to make everything work for the patient, for the business, and then of course for yourself in your job. So what's the value of identifying medically complex patients? Well, right now, it is medical complexity that drives the income or the revenue for the facility. We all know that over the past 15 years, insurance companies have not been trying to pay out more money for therapy, but they're starting to contract. Does anybody know why that has happened so dramatically over the past 15 years? I mean, prior to that, everybody refers to it as the good old days, where Medicare just paid directly for everything. And then we went to consolidated billing, and you had to bill half the charge year. And then we went to managed care, taking over the contracts, the Medicare contracts. Does anybody know why that occurred?
Medicare is in the black, isn't it?
Say that one more time.
Isn't the finances for Medicare running out?
Yes, absolutely. what happened was we had the baby boomers. People are living longer. We had enough medical advances that were able to give people a longer time for their life. And so the reality of that is that you've got people who are older who need more care, and Medicare, the system, is a business too. It has a finite amount of money at the end of the day. And so if a business isn't making enough money and they have more expenses, they start looking for other avenues to either sell out, which they did to managed care companies, or they completely go under and they're not able to function. Well, we have so many people that are on the Medicare system that their option was to go to managed care. So they started looking to the private managed care companies to manage the Medicare contracts because they found that they could offer the patient something different for a different rate, and it would allow Medicare to continue to function. What we have to understand is that revenue is no longer based on therapy minutes. Now, Medicare did this to be revenue neutral. So they thought, okay, if we actually provide the right amount of care, we're not saying you guys aren't, but we sure are seeing a lot of therapy incentivized, and everybody's getting the same ultra high therapy. We're going to change that to where we're looking at what does the patient need? How medically complex is this patient? And then they were going to pay based on that. And you have to go in and do that within a very short amount of time. So they want the care team all communicating. They want the care team to look at the patient and say, this patient with all these diagnoses, now you add another one, it is going to receive this much resources in order to manage their care. So it was going from a therapy base, because they felt like they were incentivizing everybody to provide therapy to everyone at the same level, and they wanted it to be patient specific. So now it is based on the patient's medical complexity. Take your drink your cocktail. And the most interesting thing to us as we were learning more about the patient, the PDPM, patient-driven payment model, is that dysphagia increases medical complexity. So Medicare did not leave us out. In fact, they included us at one of the highest levels that you can include the therapy team. Why? Why do you think they did that? Anybody?
Yes. Oh, my understanding is that the modifiers for the dysphagia, they're high, but what we start out as for reimbursement starts low, like 0.68 or something like that, whereas OT and PT generally stay high, but their modifiers are slightly less high than ours.
That is correct. Medicare also didn't have us decrease across the board. They didn't want these patients readmitted to the hospital, and they understood that a large number of patients suffer from dysphagia, and they knew if speech pathologists ever catch on to the fact that dysphagia is a silent issue for a lot of these patients, and we start getting included sooner, they knew that they were going to have a massive number of patients that qualify for our service. So they did include us. They included us in a way that if we're able to identify these patients appropriately, they knew we were going to be seeing more patients than probably anybody else. So the skilled nursing facilities really need you to go in and find that 68% of patients that are suffering from dysphagia. If you only find 50% of them, because that's all the time you have, or 40% of them, that's the best that you can do. But be aware that the numbers are astronomical for patients that are admitted into skilled nursing facilities that are dependent for ADLs that now also have a dysphagia that typically is undiagnosed at the hospital level. So you really need to go in and find all of them that qualify for your service. So how do you identify and communicate medical complexity? How do you do that? How are y'all doing that now? Do y'all know how to identify and communicate that medical complexity on the MDS worksheet?
At least at my facility, I'm in charge of doing the BIMs. I'm charge of doing swallow, section K, and the altered diets.
Great. That is exactly what needs to happen. If you pick up a patient that has dysphagia and you don't tie it to anything, those are considered R codes, right? So an R code, do y'all know what the R stands for in R code? Has anybody ever told y'all? Stephanie and I learned this while we were
Actually from our coder.
from our coder. It means return to sender. So it's not a standalone code. So when you're coding on the MDS worksheet, if you're just R coding dysphagia, that means it's not very medically complex because it doesn't have a medical diagnosis to link to, or what we refer to as an I code. So the I coding with the R coding together is what allows you to communicate to Medicare that that patient is more medically complex. And then of course, just like you said, Sean, you have to code section K, you have to report that in the right section. And something Stephanie and I are learning, which Stephanie did a great job of researching this. We felt like we were missing something, and this may be the way to really connect a dot for you guys, is you need to be included in the coding on section GG, which is functional abilities and goals. Is anybody included in section GG currently? I mean, this is a big piece to the puzzle because it has to do with prior level of function and where the patient is now. And when it refers to eating and oral hygiene, a lot of people thought PTs and OTs were the ones who should code this section, that it was just the physical act of putting food in your mouth or the physical act of being able to brush your teeth. But it's more than that. And when we read the actual definitions of it, we realized, hey, the speech pathologist really needs to add section GG as part of something they're included in. And I think if we do this, it'll tie the dots together a little better for us to communicate to Medicare exactly how medically complex these dysphagia patients are. So it's super simple. This is how you're going to do it. This is how you communicate them. You have to identify them first. You have to evaluate that patient right as soon as they're admitted. You have to find all 68% that qualify, and you have to do it quickly because you have to code them by the R date. Does everybody know what the R date is in your facility? Do you have 5 days? Do you have 7 days? How long are they giving you till that R date where you have to report your findings? Anyone?
It's usually the 7-day.
Yeah, so you usually get 7 days, great. And you know, in that 7 day, they're also usually doing a look back as well to make sure that they didn't miss anything.
They're also shortening those now if they're going to account for the IV fluid and stuff like that.
So
And
some
since-
1 to 3. It's
Yeah,
actually
1 to 3 days we've
It's a
seen.
1 to 3. The GG code, the GG on the NGS really is coded in 1 to 3 days. So that's historically done by, because the reason I only had like 2 speech pathologists yesterday in our conference that actually were included in that part. I mean, we had like 29 participants. So I was actually happy that they were included in that, but that actually needs to be coded in 1 to 3 days in general. So you're right.
Now, this is where I would bring my PT and OT friends and donuts and coffee on Monday morning and say, oh, I really want to be included on this GG section. Here's some donuts and coffee, get to know them, make sure they call you, text you, let you know that that piece is happening, that you want to have input, put a communication form together, anything you can do to bring the care team closer together, because you don't want to miss your opportunities where it really counts. So you really have to know when your facility assessment date is. If you don't, ask somebody, because you don't want to miss that opportunity to communicate it, because that's going to affect the patient. So if the patient has a really high need and we've missed connecting the dot on medical complexity, what's going to happen? That's where they come in, they give you the tap on the shoulder and they say, you get 15 minutes with Mr. Jones. And you know that you need a good 45 minutes, but we haven't been able to connect those dots. So being included early is key. You have to be included before that R date so that you're prepared on R date to give all the findings that you have. and even go back to a patient. You know, a lot of times we'll see a patient in the morning, we'll see a patient in the afternoon, we go back, they're completely different after lunch or after they received a medication for another medical diagnosis. So be sure that if you evaluate them once and you're on the fence, you go back and take a look before you have to report those findings. If you're on day 3 to 5, just finding out that you think a patient needs your services, it's going to be really hard to tie all that together quickly. So this is where you have that discussion with your admissions coordinator, and Stephanie and I put a form together that will hopefully allow you to have a very simple discussion with them. It's super simple. They could fill it out when somebody's admitted. Their daughter could fill it out if they're bringing them into the facility, and give you a few key pieces of information that let you know, yes, in fact, this patient needs me and they need me right now. So hopefully you guys will like the form that we put together for you. This is Stephanie's 7-day plan. So if you know your ARD date is in 5 days, you may want to adjust this a little bit, but I'm going to let her walk through the 7-day plan. We always say if you have a plan, you're much more likely to achieve what you're trying to do for the outcome. So we just try to lay out a plan because everybody says, tell me what to do, right? Just tell me what to do to make all these dots get connected.
And this is actually in the packet. If you didn't receive the email, it is going to be in the chat. So so it's in a PDF version of this. So basically, you know, the most important thing, as Piper says, being involved as early as possible. If you can be involved in day 1 or 2, that is so important. Any diagnosis that's high risk, it needs to be captured, and we put a list of them right there in this little white box. Any patient that's coming in with those diagnoses or a combination of those diagnoses really should be evaluated for speech therapy. And look at the patient, you know, when you go and evaluate the patient, you're the professional, you're the one who's going to determine whether or not the patient does need your service. You then you get your referral, you decide if the patient needs a diagnostic evaluation, whatever's available to your facility, whether that's modified or fees, if the patient needs it, especially if they're coming into your facility. You go to bedside, they're into your facility, you know the patient's having a swallowing problem, this is not documented anywhere. This is where an instrumental is going to be very important. You're going to code your section K in that 1 to 4 day period. And then on the 7-day look back, we're going to, you know, determine, do we get everything in, do we capture everything in the MDS worksheet that we needed to in order to add the medical complexity to this patient. And then we'll talk a little bit about I-coding, how you can get that, how you can get your care team involved if the patient's coming in without a linkable I-code, some things that we can do to get the physicians on board a little bit later.
Great, thanks, Stephanie. Does anybody have any questions about the plan? Do y'all have a pretty cohesive plan that's working right now? Do you feel like the communication is going well at the facility level to get all of that on the MDS sheet?
Rehab Synergies has a form that we fill out for the section K and the diet and dentition, and then we upload it into our point-click care. So the communication, you know, it's there for access, and it
That's
seems to be
great.
working.
Well, and let me tell you an interesting information that I got from Medicare, because I'm on the Novitas email link, and they were sending out to get comments about the PDPM. They always send it out to their providers and say, hey, we want to, it's a comment period. We're looking at reevaluating the PDPM, and that caught my attention because I thought, well, we just got in PDPM. Why are we reevaluating it right now? Especially during the pandemic, or right after all of this with the pandemic. The reason they're evaluating it right now, and you're just going to be floored when I tell you this, is they intended for it to be revenue neutral. But because the communication has improved so dramatically between the care teams, they are now paying out $1.7 billion more due to PDPM. So it ended up not being revenue neutral, and they're realizing the patients admitted into the SNF are actually more medically complex than they originally realized. So I think it's a valuable time. Stephanie and I were excited that we're able to make a comment about that, because I think what happened is there was a disconnect between understanding, you know, they thought they were just incentivizing therapy. But what was actually happening is we were trying to get therapy to all of these patients every time they're admitted into a nursing home. It's few and far between that the patient doesn't need a lot of care. That's why they're going into the nursing home. So I think there was a little bit of a disconnect of them thinking they were only incentivizing therapy. And then many of the patients actually did qualify for therapy. And when we switched to this documentation method, we made them realize, oh, there were a lot more patients that qualified for therapy than we originally realized. So I think they are looking at it, and now I can tell you where they're gonna go is to outcome measures. They're gonna start looking at outcomes. They've been trying to get there. I'm sure the pandemic put them a little bit behind. But the exciting thing is, you know, when we have mobility come in and show you, I think you're gonna have to prove that your exercises are working, and standing bedside looking is probably not gonna do that. So we're gonna give you some tools or introduce you to some tools that we are seeing that are exciting, that are coming on board in many parts of the country. And this one's actually out of Canada, so that we can actually measure what we're doing to document that progress. So, you know, once Medicare learns a little bit more, they change the rules for us. And so I see that it's coming, and we just have to stay a little bit ahead of the game. So that's gonna be an exciting thing for you guys to see. This is the admission form. So if you don't know your admissions coordinator, please go get to know them. We tried to make this as simple as possible. A lot of admissions coordinators don't realize that dysphagia is not a primary diagnosis. So I think the big issue here is that we're showing them all of the diagnoses where the patients have a high risk for having dysphagia as a secondary issue. So we just want to know how many, you know, medical diagnoses does this patient have, so we can get included soon. Then of course, mechanically altered diet is much more obvious and needs help with daily care. So if you can get some information that, yeah, needs help, yes, with brushing teeth, that's part of your section GG. If the patient can't take their dentures out, clean them, and put them back in themselves, how high risk is that patient for developing an aspiration pneumonia if they in fact have dysphagia? It's a big deal. I mean, we had somebody call us the other day to consult with us where we had done the modified hearing swallow study, and what they realized is that they had missed the ARD date. The patient couldn't get the cup to their mouths to be able to drink the water, and when they did, they took a sip, you had to tell them to swallow because they had an oral hold. And once you told them to swallow, they could swallow. And they're saying we haven't generated enough resources to adequately take care of this patient. Who's gonna do that? We're spread thin. We didn't know he needed that much assistance. So it's devastating when you miss that reporting period and you're trying to scramble to get included. And we were educating the SLP, if you had been included in that section GG, this would have come up much sooner because the nursing just didn't know what they didn't know. So you're trying to get salient information in a very short amount of time. Anything more complex than this, and you could be, you know, they're not going to do it. So we try to do something super simple that the admissions coordinator, if they come in on Saturday or Sunday, they can throw it in your box. You can review it and know, hey, this is a patient I need to go see. So hopefully this will help you find those patients that qualify and find them from day one, because day one really might be day 3 if they came in on Saturday. So that's where you get into crunch time. And this is where you would get your section GG information. So section GG has historically been done by PTs and OTs. You want to talk a little bit about section GG?
Yeah, and so this is these are just functional abilities and goals. You'll see they have like mobility codes that they code in there too. This is like, you know, how much level of assistance does the patient need? Is the patient contact guard, whatnot? But the two areas that are specific for speech pathologists are the eating and the oral hygiene. And on the eating section, as Piper mentioned earlier, it does include the physical ability to bring the food in the mouth, which would usually be what the OT would document and, you know, and report on. But it also includes once the food enters the mouth, the ability to swallow the food. So if you think about some of your patients who are on modified diets, who are very impulsive and they eat very quickly, and they're constantly needing cues, this is your opportunity to code in there that this is a patient that needs some support. I'll show you where that section would be. You can look at those options here in the next slide. And the other area that we need to be included in or give some input on is the oral hygiene. And again, this is typically coded by the occupational therapist or nurse. This is the patient's ability to do this. It goes from independent to being completely dependent or not being able to do it at all. So we just want to be sure we're giving some input because we know oral care is so important to our patients with dysphagia.
And this is why, I mean, the more that Langmore has reported or the studies that she's done, now there's one specific to SNFs. This is just her general study from 98. She has another one from 2002 that's more specific risk factors for SNF patients that's also appropriate, but they share these same risk factors. So being included in section GG is because these patients that we're seeing that we now know have dysphagia, a lot of times they are at a higher risk for developing aspiration pneumonia because of these additional reasons. So everybody, you know, thinks that, or a nurse, a CNA might think that a patient's totally fine as long as they have a tube feeding because they're not actually swallowing, when we know as speech pathologists that that's going to increase their risk for development of aspiration pneumonia. You're not getting input into the swallowing system, and for whatever reason that the swallow was broken, it has still not been fixed. You've just bypassed it. So we aren't really addressing the swallowing problem by bypassing the swallow. We're just giving them an option to get nutrition a different way, but we're not addressing all those issues. So us being aware that oral care is so important, oral hygiene is so important, being able to actually put the toothbrush down, then brush their teeth, put their dentures out, put them back in. We have very few patients. They come out to the van holding their dentures. They can't get them back in. They don't know how to do it. We have to help them place them. So, I mean, that's a big deal for these patients who also are struggling with multiple other factors, including the risk for aspiration pneumonia. So just be aware, and this is just something that you could share with your PT and OT friends when you, as to why you want to be included. I think when people know why, they're much more likely to include you. And this is how the section looks.
So you see this is like a 6-point scale from independent to completely dependent. And if your patient is, if you look on the very far, if activity is not completed, for example, if the patient has a PEG feeding or is on a PEG tube, you would code it in as an 88 because you weren't able to complete it due to safety issues. But just to kind of take you an example, going back to the patient that was needing some level of assistance, you know, for a patient who's needing a constant cue, you just have to decide, is the supervision with assistance, do they need verbal and tactile cues? That patient might follow in the 4. And then there's number 3, where is a patient needing this at least less than half of the time. So those are, like I said, key areas that you want to make sure that you're capturing whenever they are coding the GG section.
Does anybody have any questions about that? Do you think that they will allow you to be included in that if you speak up and, you know, let them know this is a priority?
At least on my end, this is usually coded in Rehab Optima. So it's like PT has their section, OT has their section. I think they'd probably have to rework how Optima does things to allow us to do this section.
Well, and you know, the other part is if you could have a communication form with your PT or OT and just let them know, here's the 3 patients that I've evaluated that would, in this section, I would put them at a 3. You can, you know, if they're going to make them lower, that's one thing, but if they're going to make them higher, then at least they're aware that you would have placed that number differently and they can enter that based on that care team collaboration. It's kind of getting them to call you when they're on the fence or making sure they know that you can help with this section, even if you communicate that before they do their evaluation.
Yeah, even if a patient's able to do this independently, you know, how many patients do we have? This includes patients who are needing multiple swallows to clear a bolus. I have some great examples I can share with you guys of like how this would fit into like your nursing home. So a patient who can independently do that just fine. The occupational therapist is going to say, okay, great, they can bring the food up to the mouth. But they're swallowing 3 times and drinking a glass of a drink of water every other bite. That's not completely independent. And so those are the patients that we need to capture because physically they have the ability, but there's some other issues too. And of course, you mentioned patients have cognitive issues as well. They would also fall in here and be coded a little bit lower than maybe what the occupational therapist would code them in or as a nurse would code them in.
Because if it's a patient, you're thinking that they might need to sit at the rehab table, or there's more assistance that they need just because they need those cues to get through a meal, then that's your patient that you want to be sure to communicate. And I think just if you're in a care team meeting, if you let them know, hey, I can really contribute to this section, if we have the same patient, just shoot me a text and let me know you're coding that section. We do initials or whatever they do now. And you could say 3 or 2 or, something really quick, because if they're thinking 5 or 4 and you're really thinking 3, we're not really communicating that accurately to Medicare. So just let them know you want to be included. Try to figure out a system that might work if you're working in different systems, because we've learned this is really important to making sure you get enough resources to provide care or provide that additional assistance. So we've learned that the R code isn't enough to capture medical complexity without actually putting it in the correct place, which is section K. So that's kind of your foundation for being able to communicate that a patient has difficulty swallowing. So it is a must, and there's a couple of sections to section K. So there is this section that most of us say, we're very literal. We have a lot of type A speech pathologists. When it says complaints of difficulty or pain with swallowing, this doesn't mean the patient has to complain. Stephanie and I looked into this section. We're like, who wrote this section? Because we would have written this much differently. But what it does mean, it was a bunch of nurses who came up with how to code this section K, and now we're being included. But they didn't go back and rewrite this based on what a speech pathologist had to say. So complaint of difficulty swallowing for a patient who may or may not be able to complain to themselves is just difficulty swallowing. If you identify that difficulty as a professional, you're the one making the complaint that this patient has difficulty swallowing. So we made our t-shirts difficulty swallowing, because we felt like people were leaving that out. And we have patients who kind of fall under that broad category of difficulty swallowing, but SLPs were saying, well, they didn't tell me about it. I saw it, so I'm going to say none of the above because they weren't coughing or choking or holding food. But you really need to understand that in a skilled nursing facility, we are the advocate for the patient that may or may not be able to communicate their own needs or may not know how to communicate that. So if you're noticing a patient can't get through a meal, they need a lot of assistance, you're having to cue them to swallow 3 times, this is difficulty swallowing. It should not be that hard to get through a meal. So you have to do this really quickly, because usually by day 3, you're wanting to start to report your findings. And then of course, there's a second section for section K. So just be sure if you got the patient on a mechanically altered diet that you're indicating that, right? So you want to be sure you do both sections of section K and don't get left out of this section as well. So R coding alone will not increase your medical complexity. It's a return to sender code. You really have to connect it to an I code to get an increased level of medical complexity. So I code linking is required for that, and it allows you to give the appropriate level of care to the patient if you are in fact able to say this is why the patient is having dysphagia. And we know dysphagia is a secondary diagnosis. So we are looking for that cause, especially if there's nothing in the medical diagnoses that seem to be causing dysphagia. So we think that we found some information that might be valuable to helping you know how you can link that when it's when your gut tells you that something is more going on, but you don't have the documentation to support it. So that's typically why we're doing instrumental evaluations, where they do an MRI, or they're looking for what is causing this neuromuscular problem that we're seeing on the modified variant solve study, or the fees, when we don't have a medical diagnosis to support that. So we approached our physicians about it, and we'll be sharing how you can have that conversation with your physicians. So here's the difference in R coding, I coding, and making sure that you document the presence of a swallowing disorder, if they have neurological presence, and that you capture this correctly. Because for the care of the patient, for the business, it is important. And you can see the dollar amounts on the far right-hand side. It is important that you generate enough resources to treat that patient appropriately. So we had somebody last night in our conference say, well, what if the patient has really no other issues and they really do just have
It
dysphagia.
was a positioning issue.
Just a
It's no
positioning
longer-
issue. Well, sometimes you're not going to be able to I-code link that. Well, that's not the patient that you would treat for 45 minutes. You would work as part of the co-treat team, or you would go in and see that patient for 15 minutes for 2 weeks to try to work on positioning. If something doesn't fit, you can't put it in that box. You can't put a round peg in a square hole. This is not trying to make every patient qualify. These are, if we have 68% of patients that are typically going to qualify anyway, it should be a sine wave and not a straight line of everybody getting the same service. So there should be some peaks and valleys in what you're doing. But a lot of our patients are so complex on the skilled side that it really changes that for us because we know that.
Does anyone have any questions about that before we kind of move on? Are you guys able to, is that something that you understand in your facilities now about R coding and I coding? And I know that a lot of the electronic medical records now, I mean, the EHR systems do a lot of linking for you guys, that's great.
Okay, well, the reason that sometimes we get so frustrated is we feel like we only have 5 or 6 codes that allow us to link for dysphagia, and we know not every patient falls into some of these specific categories. But there is one code here that is unspecified. And one of the issues that Stephanie and I are having is that we were noticing that patients had diagnoses that might fall under cerebral vascular disease because of the combination of diagnoses that they had. So we approached our medical director and we said, look, we only have these 6 codes. We like to think Medicare knows what they're doing. Is there something that we're missing in this documentation? Like, is there a combination of these factors that could put a patient at risk for cerebral vascular disease, even though it wasn't documented in the hospital, or that's not why they were admitted to the hospital? And it was interesting. The medical director, who's been working here for 15 years, said, you know what, that's a good point. I need to take a look at that because I believe that would be, in fact, be true. So we as SLPs are always asking, what is medically causing this dysphagia? Like, we know that this patient does not have a good pharyngeal squeeze, or they do not have good laryngeal elevation. There is neuromuscular involvement. There's got to be something else that's going on with this patient besides just diabetes, COPD, and dementia. So one of the things that we learned is that if we approach the physicians with the fact that dysphagia is a secondary diagnosis, we now have this instrumental evaluation. There's been a change. I talked to his daughter in the past 60 days that really could be causing this dysphagia. Could we consider linking it to this more generic I-code? So that, in fact, is what the physicians decided. But step 1, you would want to have, or you want to follow some certain steps, right? Because you want to be sure that what you're suggesting is in fact based on fact and not just your gut feeling that something else is going on. So if you have an instrumental that provides the R code and we can document that in fact this patient does have a very specific dysphagia that is neuromuscular, then that's your first step in saying something else is going on. Now, I think this patient doesn't have just general weakness because they have other medical diagnoses. So you want to discuss with them, hey, since dysphagia is not a primary diagnosis, do you think we could link it? If they're not present, because sometimes the NP and physician aren't present, have a list of pre-approved qualifying diagnoses that might link in. So you might have this discussion at one time and then develop a system for communicating that when it is in fact true. And then this is where you would add it in, is the I-8000 section of the MDS with the specific R code. So you would put in the unspecified I code for cerebral vascular disease and follow it by the R code. And we're going to show you how to do that. So I-69.991 is kind of a catch-all, and you want to have a strong enough case if you're in fact going to tie this to a patient. If you have a patient who's just a little weak, doesn't have very many multiple medical diagnoses, You just do a little strengthening and they can get better, that's great. But if more is going on and you see a terrible swallow that is clearly not just due to weakness, then that's when you want to approach your physician and say, I know more is happening here medically than's been captured. And so we put a form together with Dr. Balmer. We just presented our case and he was doing his own research, and these are the things that he felt like would fall under a general cerebral vascular disease. These are a combination of these things. I'm going to speak to that just a little bit.
Sure, so in the cerebral, on the first section, you see cerebral vascular disease, like these are the diagnoses that are captured underneath that I code. Below that, you'll see other factors contributing to cerebral vascular disease. So these are your patients that are not coming in with a history of stroke or TIA, but they have hypertension, they're diabetic, they have hyperlipidemia, and they have dementia. They have several of these diagnoses. This is when you're going to ask your physician, my patient has 5 to 6 of these diagnoses and now having a neuromuscular swallowing problem that was documented from the instrumental. Would this be a patient that we can attach the cerebral vascular disease unspecified with dysphagia, and that would be your I-69.991.
And we have a couple of physicians in the Valley that came to our presentation. They work on our mobile clinics, and they said, we've been doing this for years. We didn't know you needed this information for this new payment model, but we've been diagnosing this for years and adding it in the diagnosis list when they see multiple factors present. So that made us feel great to learn that other physicians are already aware that this multifactorial contribution can become kind of under the general category of cerebral vascular disease. Now, that was back in PPS, and when they came to our conference, we were talking about the new payment model. They wanted to learn about it. They said, we already do this. And I thought, well, that's great, because that's really helpful to our care teams when the doctor from our clinic is diagnosing that patient and adding that I code for you so that you can present it to your clinical care team as well. So the instrumental may combine dysphagia following cerebral vascular disease. You just want to look for that in the line. And that's even a stronger case, because physicians love to hear from other physicians what their thought process is, especially when they're in a specialty field like the modified or dysphagia consultations. So this is your I section of the MDS worksheet. This is how you would communicate it under this I-8000 section about the R codes and putting in the I code linking that goes with that specific R code. Does anybody have any questions? Have y'all seen the MDS worksheet? Do you see it? I think the big takeaway from this is don't be left out. Be sure you know who is coding this section. Be sure you can follow up on your patients and make sure that something was coded in when you feel very strongly that it should have been. So if you're putting it in yourself, that's great. If somebody else is doing this section, you just want to know that person and be sure that your communication is getting through to them and they're actually following through with including it when they're coding. So how do you create and maintain a happy marriage between business and patient care? Well, this is what it looks like when you do not capture medical complexity. It can become a loss for the facility. And I just took you on a little trail path to show you what that looks like. The minimum code in for a patient for dysphagia, if they have nothing, right, is $15 to $19 per day in a skilled stay. If they're there for 20 days, that equals $380 total. If the expense for speech pathologists to the nursing home, this is with, this may not be what you're paid, but this may be with your health insurance, your workman's comp, all of the things they have to pay. Your expense to them can be up to $50 or $60 an hour. For 8 hours a day, that's $400 to $480 per day. If you have 10 patients at $19 per day, the baseline minimum, a 20-day stay, you're generating about $3,800 in income. If your expenses during those 20 days for your time on site providing care is $8,000, this means that the facility has more expenses than they've generated in revenue, or the therapy company. And what happens to patient care when we are spending more money than we're generating? Do they typically say, let's bring in a few more SLPs, or do they start saying, wait a minute, we've got to reevaluate that, we might outsource our therapy department because this isn't working for us? Right? So it doesn't really work for the facility, it doesn't really work for job security for you, and it really doesn't work for the patients because they're not getting what they need. But on the flip side of that, if you're able to capture medical complexity, here's how that can look much differently. Let's say that you code in $40 to $95 per patient. The total revenue in 20 days is $800 to $1,850 per patient. Your cost is $50 to $60 an hour, so that's $480 a day. You got 10 patients, let's average it out, about $60 per patient per day. In a 20-day stay, you've got $12,000 in income that you've generated. Your costs during these 20 days are $8,000, and now you've brought in more money than the facility has expenses. So they've got a positive. And the integrity of patient care gets to continue because there's a happy marriage between what you're doing and capturing and what the business is able to do in return for their patient. So you can see that if we're able to capture medical complexity correctly, it can make a big difference in how our business operations feel towards what we're doing on the patient care side. So this is how the patient, the SNF, and you have job security. You have to find all the patients that qualify, capture medical complexity at the highest level, code it correctly to communicate that level of complexity to Medicare, and then you have to do it in a very timely manner. And everybody wins. Okay, so this is where we get to the practice part. So let's practice.
Yeah, real quick though, does anybody have any questions? Does anybody want us to go back over anything? If you're just joining us, I saw a couple people kind of pop in.
So this is going to be an overview of how a caseload would look. I put together, and Stephanie and I put together kind of a soft chart sheet and how that would look. And I think the goal is just to empower you from the business standpoint of what you're actually generating when you're coding these patients. So that when you're having a conversation about how many therapy minutes are going to be provided, you have accurate information that should have been coded in, and you know what you're generating, and you know how complex that patient is.
Okay, so we go in on Monday, here we have our plan, and we get 2 patients that were admitted over the weekend. So this is patient 1, Ringo Starr. Admitting diagnoses was an acute CVA, currently has a PEG, came to us on a modified diet on puree thin. He does require verbal cues to slow down because he has an underlying cognitive impairment that we determined that we discovered on the BIMS. He has a history of a TIA, pressure ulcers, and a UTI. At bedside, we recognized that he was in fact having some difficulty swallowing, admitted to us on an oral diet, but we did not have an instrumental. So we decided, okay, let's go ahead and get the instrumental evaluation. So on admission, on the first day, we got this in our box. The patient had a high-risk diagnosis, he had a CVA, dysphagia, and a PEG. Was on a mechanically altered diet. He did need help with his ADLs. He was unable to do setup and then able to brush his teeth independently. He did not have an issue with BMI. And remember, we're going to help code in the GG section in those 1 to 3 day periods. I went to go talk to my occupational therapist and I said, hey, this patient is having some difficulty. Let's collaborate on that coding, please. Okay. So was there a presence of an acute neurological change, acute neurological? Yes, there was. He had a stroke. We did document a cognitive impairment. At bedside, we were able to diagnose an R13.12. And at bedside, I was able to code him in as an SI. And that was about $80. These are Harris County rates. All these rates are a little bit different based on your county. So just want to make sure that you guys are aware of that. So then we were able to link his, after reviewing his chart, we were able to link his dysphagia to I-69.39. Now we were able to code him in at a SL, which changed his estimated, or changed his cost per day. And we averaged him for a 20-day stay, we averaged him $1,912. We coded the GG section with the occupational therapist. We selected difficulty swallowing under section K and made sure that that was coded that he had a mechanically altered diet. And so make sure that all went to the MDS coordinator. So we were able to capture medical complexity on this patient and treat him at the highest level, because this is the patient we should be treating at a high level. This is an acute stroke patient. We're hoping to recoup some, prior level of function. So this is a patient we want to treat at a higher level.
And I wanted to ask y'all, does anybody get a key performance indicator, or do you get like a worksheet printout of the actual revenue that you're generating from the medical complexity you're coding? Or do they just ask you how many minutes you want to see the patient and you have a general idea? Is anybody in that situation?
General idea.
Yeah, I mean, for me, now that I've learned more about the business side, now that, of course, we really had to budget differently this year, I thought, what a great idea to really show you what you're able to capture, so that when you're asking for minutes, you are empowered to know, hey, I would have this thing on top of all my soft charts. And when they were asking me, I would say, well, here's how I coded in Nanny Jones, and that's why I'm asking for 45 minutes, because I feel like this is our more medically complex patient and the resources are there to care for. Because I think sometimes there's a disconnect between the business side and the clinical side. And just because we can generate revenue for the facility doesn't mean that everybody's connected to understanding that those patients that you're generating that revenue for need to have that care. So sometimes we're generating the revenue, we're not specific about it, and we're told, oh, well, we're going to give you 45 minutes or 30 minutes for that patient or 15 minutes for that patient, and that patient needs more. Well, this is just a way to put the care team on the same page with, we've been able to capture additional resources because this patient is more medically complex, and I would really like to have 45 minutes. It's kind of harder to argue with the facts when they're in black and white than when they're kind of, general or nebulous. I think the other piece to this is making sure that you actually, I think last night in our meeting, somebody was getting a key performance indicator to make sure that what they suggested to be coded was actually coded. So this is a good way to follow up on that. Hey, did we actually bring in what we should have to be able to care for Mr. Jones?
Okay, so let's do another example. This is patient 3. We actually had another, should be patient 2. This is patient Pink. She's admitting diagnosis of glaucoma, age-related debility, depression, and vascular dementia. She came in on a mechanically altered diet of mechanical soft and thin liquids. She has no significant history of CDA or TIA. Bedside, we did recognize the patient was having difficulty swallowing, and she did have a documented oral pharyngeal dysphagia, R13.12. So again, the admissions, whoever was admitting the patient had our sheet. She recognized the patient, he or she recognized the patient had a high-risk diagnosis. She had dementia and dysphagia. We knew that the patient was on an altered diet, was needing assistance for her ADLs, and BMI was not a concern on this patient. So this is where, again, we collaborated in that 1 to 3 day period with the occupational therapist to find out if, when they were coding that section, to be sure that we were included in that. Okay. So this is your patient that's not coming in with an acute neurological condition. Vascular dementia does not count as acute, but there was an SLP comorbidity. She had a cognitive impairment. It was recognized in the BIM. We did see that she had we did add in the R code. We were able to code in at an SF, $67.67 per day at bedside. But this is a patient that doesn't have a dysphagia I code, but is having problems swallowing. It was documented on her instrumental. So this is a patient that we're going to go with our little sheet and say, hey, physician or nurse practitioner, care team members, this patient has vascular dementia and has a change in her swallow. Can we consider adding the I-69.991? And then care team says, yes, we agree with that. Then we're able to get that all coded in by day 7. We're now in an SI category. And we've able to capture 1603.20 by ARD date. Documented on section K, difficulty swallowing, mechanically altered diet, and we made sure that we got our GG codes. And this was the form that we took to the physician or nurse practitioner who was there. We know that vascular dementia does qualify under cerebral vascular disease, and so the physician felt confident that we were able to add in that diagnosis.
So I think you can see the value of good communication between the care team, being sure that everybody is on the same page. And if the physician says no, well, you know, you were still able to code in 6767, you multiply that times 20, it's about $1,300. And you say, okay, I really wanted to treat this patient a little more, but this is a patient that I have less resources for, and so I'm gonna have to adjust that treatment. And then hopefully if something changes, you're able to get included at a higher level.
Is the that I code for the cerebral vascular disease, is that just to get the comorbidity rate thrown in as well? Is that my understanding?
Yes. Right in the
Correct,
middle, so
correct.
you're adding that. And you're returning that R code to a medical diagnosis, which allows you to show that increased complexity. So it supports you for that.
Yeah, that makes sense. I mean, I've seen tons of people for R codes, but you just get the section K, you don't get the comorbidity rate. So yeah,
Correct.
that makes sense.
Correct.
You're 100% correct. And I think just sharing this information is valuable, because I do know that a lot of therapists, when they call here, they're saying, I need to see this patient more, but I'm not able to code them in. So we look at the swallow study, we look at the diagnoses, we'll even call our physician and say, did we miss something here? This swallow is terrible. Can we make this suggestion to the physician at the facility level, because the SLP is not getting enough treatment time and they don't feel like they're going to get an outcome for this patient that's positive. So that's something that, we were on the receiving end of hearing that from therapists, and we thought, well, why is that? So it kind of set us on the path of trying to figure out, how can we be helpful to you guys? We needed to educate our physicians. And I think, as care teams, Medicare is trying to get us all to communicate on the same page. They don't want to limit the patient from getting what they actually need. We also don't want to say a patient has something that they don't have. So I think you want to build a case for these patients that you really truly feel like you need those additional resources and you can get a different outcome. So that's the patient you want to really go the extra mile and connect those dots and make sure that you can code a little higher, because you want to spend a little more time.
Is that document that you had with all the ones that, yeah, that one, is that in the PDF that you guys gave us?
It is.
Okay.
And even if you're getting an instrument, I'm sorry.
Yeah, I had the same question as you guys did back when this all started. Well, I guess a year and a half ago or whatever. I saw that too, and I thought, okay, that's a great way to get more reimbursement. I was trying to get ahead of it, but I took that to our coders, and they were like, hard no on that. They said that the cerebral vascular disease that was intended to be linked, from a previous stroke, like late effects. But if the general thought process is now that you can get it for these other things, then yeah, that's awesome.
And it really is getting your physician on board to help add that. Some physicians will really, appreciate that you've brought this to their attention and really support you. And there's some that may not feel that this qualifies. Everybody has their opinion, but our physicians who are seeing the swallowing side of it definitely feel differently, because they are seeing a swallow that has changed dramatically. And we're saying something else is going on, because we know this isn't a primary diagnosis, and this doesn't look like a little bit of weakness or loss of cognition. So I think that's why our physicians are so on board with really supporting you guys. If we can find this for you, we do suggest it to your physician.
Yeah, Dr. Bonner made a really good point. We're collaborating with him, trying to figure out like how can we get an I-code on there. He made a really good point. He's like, a lot of times we see patients and they may not get an instrumental, but just based off of their clinical symptoms, we're saying this patient probably had a TIA. We're documenting these things as physicians, not necessarily with an instrumental, especially for some of our patients that are, that are 90-something years old, had a hip fracture. That may have not been their primary concern when the patient went in. They were just trying to get the patient stabilized and over to the next level of care. So, this happens all the time to our patients, not only if they're having an acute neurological change, but swallowing too. I mean, once from the hospital to us, we're the ones at the SNF recognizing that the patient's having a swallowing problem.
So this is how a caseload might look if you had your little soft chart and your pieces of paper and you knew what you were coding in for those patients so that you have a general idea about the revenue and income that you're generating. So you can be responsible to the business and responsible to the level of care that your patients need. By this, you can tell that there's some patients who coded much lower, and there's some patients that coded higher for that medical complexity. So this helps you generate your peaks and valleys of who needs more care, who needs less care, and it gives you the factual information behind why you would be asking for more care under this system. So you can see that in this model, the patient wins, the business wins, and the SLP is able to maintain job security because the costs are less than the revenue. So after hearing all of this, after the entire presentation, everything we've said today, what do you think is the most important thing you can do for your patients and your facility under this PDPM model?
You guys can type in the chat.
You
You
can
can
type
type it in, shout
You
it
can
out.
take a drink of your mocktail cocktails or you can shout it out.
Medical complexity.
Wonderful.
Capture and document medical complexity. Here you go, you guys. Hope you had some fun drinks to drink with that. That's exactly right. That was the whole point, you guys. I really appreciate you guys coming. This is the point in the presentation where we are really excited to share with you guys the next level. It was just like Sean said, getting ahead of things. We know outcomes are fixing to be exactly where Medicare is going to focus. And what we are looking for, not only through our evaluations, but is for you guys as part of your care team in the facility, how do we follow through and carry through treatment that is meaningful, valuable, and hopefully gets you to a great outcome. When I saw this, or Stephanie brought it to me, she did all the research and brought this to me. I said, oh my gosh, this is exactly what I've been waiting for. It's the little mobility device. And so at this point, I'm going to turn it over to Evelyn and Gabby, if we're able to get them on screen and let them tell you all about their mobility biofeedback device. And you can ask questions. It's an interactive time. And we stopped a few minutes early so that you could see this because it's a game changer, in my opinion, for how we're going to go forward as Medicare continues to change and contract and show these insurance companies that we are so valuable in managing and treating dysphagia. So you guys, is Evelyn and Gabby online?
Yes.
Yeah, we'll just stop sharing our screen.
We're gonna stop sharing our screen, take a drink of your cocktail and
Yes,
just sit
have a
back and
drink.
enjoy the show. It's impressive. Hi,
Hi,
Evelyn.
everyone. Hi, how are you? Thank you so
Good.
much for the incredible intro and again for welcoming us. We joined the session yesterday and it was just so great. And I've learned even more details today. So it's just fantastic. And I know it's a lot of work you put into it. So on behalf of everybody attending, thank you so much and cheers. I had rosé yesterday. Today it felt like a beer day. So now I'm having a beer here, but cheers. Thank you so much for having us. So my name's Evelyn and I'm here with a company called True Angle. And we have created a device that uses SEMG technology. And the basis of it is that it's going to help patients help adhere to their swallowing exercises, because we're taking a technology that has historically been, relatively big and inaccessible in clinics to something small and lightweight and mobile and easy to use. So I'm really excited. We have a project running with Stephanie and Piper where we're going to explore how this tool can help them in their workplace and with the SLPs that they are working with. And I'm just very appreciative to have the opportunity to show it to you today. So it's really fun because the most impactful way to learn about it is actually to see it in use. So I'm going to do a demo of the device for everyone. And Gabby's here. Gabby is one of the creators of the device. She has a long academic and clinical background, and she's going to be on the chat. So I've dropped my email address in there, first of all, before I get started. And Gabby will be happy to answer any questions you have as I step through the demo. I'll be sort of distracted doing that. So feel free to put any questions in there. And also, if you're comfortable and you'd like to share your email address in the chat, I can always reach out after with more information about it that we didn't cover today. And I know everyone's busy, so I'm happy to reach out to you on Monday morning. So let's get to it. I'm going to start by showing you what the device looks like. So some of you might be familiar with the large EMG equipment or machines that you've had in the clinic. I think it was Piper was talking about a trade show maybe that you went to, where they rolled in a large screen and you're like, I have to have this. But at this time, it's very expensive. It's hard. It only gives us access to patients to use it when they can come to clinic, which is sometimes a challenge. So really the team at Triangle took that large piece of technology and brought it down into this, and this is not even it. This is the box for it, tiny device. So inside of this, first I'm just showing you, this is the case that it comes in. It is called the Mobility. And I think Gabby will probably drop the website in as well that you can check out. On the back is just where the charge cord plugs in. So hopefully everybody can see that clearly. And in here is the device. So this is the tiny little piece of equipment that has, I think, like Piper said and Stephanie have talked about, is really transforming the way that patients feel connected and empowered and engaged with their swallowing exercises. So this is moving people away from just pen and paper, putting something down, telling people to go and do their exercises, into the future, using apps, using technology to our advantage. And I'm really excited about those benefits. So I'm going to show you how it works. It just has a slight magnet. So it just magnets into the case, and that's where it stays when you want to plug it in to charge it. And I'll show you, this is the back of it. So these are the 3 sensors that are going to communicate with the technology on our app to track the exercises and the hopefully progress that the patient is making. So this first one here is really the reference sensor at the top. And then these 2 will actually sit on the belly of the muscle and transmit the signal via Bluetooth to an app that will capture all of the exercises that are being completed. And then these 3 little dots in the back are just for charging. So this is how simple it is. I can't let you hold it in your hands, but I can promise you it's very lightweight. It's totally painless. You don't feel a thing when you have it on. And yesterday I was saying, oh, I should have just worn it the whole time, but then I was afraid people would be distracted. Like, what does that girl have on her chin? Which is where I'm going to place it. So I'll just show it to you now. This is the on button. So this little button, just push it, it's flashing green. That means the device is on. So now what I'll do, I'm going to attach the adhesive to it. So the way that it sticks onto my chin is we use a double-sided adhesive. It looks just like this. And these come with the Mobility device. And if people have an ongoing subscription, we send these out automatically. So you don't have to think, or the patients don't have to remember to try to order more adhesive. So they just get sent to your door. And it just sticks on the back like this. And then I just pull the backing off, which I'll show you here. And it looks like that. And then what I'm going to do is put that first dot just on a bony prominence. So on your jawline here, the mandible, I'm going to try to just use my finger to place it like this. And the other 2 will just, again, go onto the belly of the muscle. So there you can see, hopefully everyone can see clearly that I have it on here. The green light is on. Everything is so far working smoothly. What I'm going to do now is share my screen so I can actually show you the app and how the device connects to the app and how it works when a patient is going through their exercises. So I'm going to share screen, and bear with me, we're all learning technology together, but hopefully this works. Okay, Can everybody see my phone screen here? Great. So as I mentioned, this is the app, which again, it's very simple. When you get the device, the mobility, you download an app, you enter a code, and that's it. Your device will actually connect through Bluetooth very simply and easily to your app. You don't even have to go into Bluetooth and search it the way we do with other devices. It is automatically connects. So super easy to use. In the top left-hand corner, you can see that there is a battery symbol and our little sort of smiling cyclops here that are fully blue. That just means that the battery life is full on it and that it is connected. So if it wasn't connected for some reason, that would be X'd out, but we can see we're connected here. Then along the top in the middle, there are 8 empty squares. Those squares represent the different exercises that are intended to be done per day by the patient. And again, if a patient can't get through all of the exercises, they're not forced to do that. And I'll show you how that works. But there are 8 different sets of 3 different exercises each, done 3 times. So a total of 72 swallows. And again, what we're trying to accomplish here is empowering and engaging the patient visually to see what they're doing in terms of their swallowing exercises, to feel like they're connected with it. And you know, Piper and Stephanie have both said in other areas like physio, we have better, maybe more tangible or quantitative ways to track things. There seem like there are tools that can be used. And that's really one of the important features of this device, is it is arming you and your patient community with a tool that is interactive. Before I get into it, I'll also mention that there is a clinician portal. So when I say clinician portal, what I mean by that is it's web-based. So it's just a site that you go to through the internet where you can log in and actually see a patient's progress and adherence to their exercises. So this is where you're really able to connect and communicate with the patient to, you know, encourage them, support them, identify maybe where they struggled, and you know how to move forward better together. So it allows for that interaction. All of the data, it is anonymous in terms of it doesn't list the patient's name. You have to give them a number. So we do keep things HIPAA compliant, but basically all the information is traveling from the app into that portal where you can log in and see it. So that's the other, I think, sort of game changer here, is connecting the clinicians into the patients, even from a distance, which of course, with COVID, we're seeing so much growth and advancement in terms of mobile health, telehealth. This falls right into those categories. So then I'll just point out a few things at the bottom and then we'll get started. Right now we're in the training component here. So that's where we're going to actually do our exercises together. Tracking is where we'll look at the end and we'll see what we've progressed through today and over time since I started using the device. And Coach is just a little portal that shows us, how do I place the device again? How do I calibrate it? Any simple, almost FAQs or questions you might have are captured in there, and I'll show you that as well. So what we're going to do, I've already skipped through. There is a tutorial when you first start using the device that teaches you how to put the adhesive on, how to place it, how to calibrate it, how it's all going to work. So I've skipped that today in an effort to save time and not pull all of you through that. I've just sort of demoed it live here, but just to let you know that that is how it works. So today we're going to start our exercises. So I'm just going to hit start exercise on my phone. And it says, please put on your mobility. I've already done that. So I'm going to say confirm placement. I feel it's well positioned. Now I'm going to stop talking. So I'll give everyone a break. You can have a sip of your mocktail cocktail. And I'm going to begin the baseline. So this is, again, just eliminating all of that noise around us. We're just making sure that the device is really clearly communicating with our phone or iPad, whatever tool we're using. And so I'm going to hit begin baseline. And for 10 seconds, I'll sit still and not talk. And you'll see it'll just generate a nice clean line if we're well connected. Okay, you know what? I swallowed right at the end, which is probably okay, but I might redo it just to make sure that we do go into this really well and nice and flat. So let's try it one more time. Oh, sorry, did I hit yes? I might have accepted. That's fine. We're going to go with it. Now what we're doing is a calibration. So the way I like to describe this is that this is really patient specific. This is capturing 5 of their regular swallows, and that is going to help us establish the target that they will try to achieve in the exercises that they do, ideally each day. So right now I'm going to do 5 swallows. It's going to, in essence, capture a baseline that's going to help set a target line for the upcoming exercises. And you're going to see that there's an actual dotted line that will show up coming up. And that is based on my individual swallows that I'll do now. So I'll just have a little drink before I get started. And now I'm going to start to swallow like I normally would. So I just hit, I'm ready. And when I'm done, I hit, I'm done. So that's 1. And we can go through these relatively quickly here together. And 1 more. Okay, so there you can see how easily and how well a device is capturing all of my tiny movements and swallowing. And we've got sort of our baseline set now for calibration. So here's where we get into those 3 different exercises. So the first one is a regular swallow again. So this time you'll notice that a line comes up that's actually indicating, a target that I need to hit with my swallow. So I'm going to do that now, and I'll show you what that looks like. Great. And when you see a full cube like that, that's totally opaque, that means that I have met and exceeded the target. I did a great job. I'll show you an example of another one coming up where I don't quite reach the target or the full goal, and that shows a different type of square. And at the end of all the exercises, it's going to summarize that for us. So we'll be able to see it at the end, and I'll show you that. So I'll do the next one now. Okay, and 1 more. There we go. So we're done the first set of exercises. We've got 2 more ahead, and then I'll show you the summary. So this one is an effortful swallow. So what I can tell you about this one is that you'll see the target line again, and it's going to feel harder for me to achieve it. So it is a tougher swallow. And, it's hard for me to have you feel that, but I'm just going to put as much effort as I can to hit that target line. I'll show you what that looks like. There we go. So full marks on that one. Again, you can see I've done well there. There we go. So done those 3 as well. And now we're going to go into what we call a Mendelssohn or held swallow. This one is where we're trying to reach the target, and we're also trying to hold the swallow for an extended period of time. So there's almost 2 different portions to achieving this part of it. So I'm going to do these 3 in a row. And again, this one is harder, and I'll show you one where I fail or don't quite make it and what that looks like, just so you can see the difference. Okay, so you can see I went above the target line, but I didn't hold it long enough to reach the goal. So you can see I did well, I just didn't get full points there. And that's why the square looks a little bit different. There we go. I was joking about this yesterday. I'm like, this one actually is pretty tough, even for me, which is good. I think that's an important thing. Okay, did I get it? Oh, almost. So there you have it. That's the summary of the 3 different exercises. I just did 1 set today. So I've done 1 of 8. As you can see along the top bar, that square is filled in. So this is the quick summary of the regular, the effortful, and the held. And what I'll show you now is normally if I were to hit continue, we would just go into the next set of exercises. But what we're going to do right now is I'm going to hit stop exercise. And instead, I'll just show you a couple of the other areas within the app. So if I were to hit track at the bottom here, you can see that there's a summary of how I've done today, this week, and overall. And again, this is the type of information that's transmitted between the patient and the app into the clinician portal if you both choose to connect in that way. So here you can see what I've done, 13% of the required exercises or the target of exercises, regular, effortful, and held. And there is a slight difference between, how I've done in each category there. overall for the week. And so you can see when I did a number of demos with the device yesterday. So you can see on Friday, I did a number of exercises. I haven't been doing too much of my other homework earlier than that, according to the app, but that gives you a quick view to what that looks like. And then when I do, oh, and I'll scroll down so you can see it in each of the different categories there for days of the week. And then for overall, you can see how I've done. And this is again, just summarizing how much of the regular and what did I achieve for, complete or incomplete for each one. And also at the bottom, you can see kind of like a Fitbit, the swallows completed since the beginning of the use of this device. So that's kind of an interesting number. What we've heard from patients is that they do feel a sense of accomplishment, getting a bigger and bigger number here over time and getting closer to their goals. And this is just showing, basically how much I've accomplished overall. And again, this information can be shared through the clinician portal. So that's what the summaries look like. And then if I go under coach, you can see the different topics that I mentioned there. So placement, calibration, exercise, and track. And I'll just give you an example of what one of these looks like. So if you were to hit placement, I don't know if you can hear, there's a voiceover also speaking through it. It says, this is how we go through these different steps. It actually shows how to remove the adhesive backing and how to place the adhesive on. So just in case the patient has forgotten or anyone needs a reminder, this information is easily accessible here. And then you can see the lights, locating the window, turning it on, and then the placement. So again, with the window facing out, where you put it. And here's a quick little video snapshot of how to place it. And that's how easy it is. So those are just some of the tutorials. There you have the device on that are available in that section of the app as well. And then the little dots at the bottom that say more, that's just where the terms and conditions are and the technical information about your mobility device in case we ever had to connect and address any kind of technical issues. So that's really what it looks like. Again, it's totally lightweight and painless, really, really simple to use. It was designed to help people work with patients remotely. We were talking about it. We're going to look into this more, but there are some remote telehealth codes available that do apply to this device. And we're exploring that now in terms of what that looks like, because there could be some reimbursement opportunities there as well. And yeah, it's just, we're very excited to explore this further, of course, with Stephanie and Piper, but we would welcome reaching out with any of you. We're always looking to grow our community in terms of patients and clinicians and collaborators. So we're just excited to connect if you have any interest in this device, or you could see it, being used with your patients or within your practice. So maybe I'll open it up. I don't know if there were any questions, anything else. I see a couple in the chat, but it looks like Gabby covered those. So again, if you want me to email you any further information, you can share your email with me over chat, or I've shared my email as well, and welcome any communication back and forth. So I think that's it. Any other questions from anyone? Or Piper and Stephanie, anything you want to grill us about? Oh, I think you're on mute, which.
Hey, no, I thought that was great. I was just excited to share that with everyone. I do think, knowing, being really close to Medicare and getting their newsletters, I know we're headed in the direction where they're starting to look at outcome measures and how we're getting patients to those outcomes. And so, when we saw this, yes, I'm very aware of biofeedback, but in the setting we're in, where healthcare is contracting and there's not a lot of resources, this is accessible, it's affordable. I think the question in probably everybody's mind is, how would we use this with patients who can't cognitively participate at a high level? And I think that's kind of where we come in. We're looking for some options through instrumental evaluation, interfacilitated weighted boluses, how we can get that patient a baseline and then allow you to facilitate exercise. So I think that's where a lot of interest lies for us as well, because, yes, for the patient who's very cognitive and can participate with you, this is going to be perfect. And we do have patients like that, but we also have patients on the opposite end of that spectrum, and being able to actually do something of value, hit those targets that we know gets closure and can keep them from getting an aspiration pneumonia or improves their quality of life is really important. And if we can document that we're actually doing something that results in an outcome, I think it's gonna be a win-win for our patients and for us clinicians. And so I was just hugely excited to see a device so small, so accessible, so affordable, so simple to use. You know, that it really piqued my interest for all of our clients and all of our patients and all of our, you know, facilities, rehab companies, just being introduced to it, knowing that there are some options. So that was just really important for me to share with everyone. So I appreciate you guys being here.
Thank you so
I'm glad
much.
you're good and showing everybody the device. And I'm just impressed with what you ladies have been able to do with it. And I just want to get the word out that this is another option for patient care.
Thank you so much to you both. Your support and just encouragement has been fantastic. And I know the whole True Angle team's really excited about, you know, bringing this to market. So thank you. That's great. Thanks everyone for listening too. Appreciate that.
Yeah, we appreciate both you guys. And for everybody who's still on, we had a little, were you able to pull a poster over? We have a little poster that we had put together.
It's in your packet.
It's in your packet that we emailed you. It has to do with the broken femur, broken swallow, and it was basically a comparison of just how physical therapists are evaluating and treating their patients if they have a broken femur to rehab that, and how we would be treating that as speech pathologists. I really want to move us more into the exercise physiology realm of how we view ourselves when we're, are they able to see it?
There it is.
Yeah, okay. You know, we've really got to get away from just, you know, assessing aspiration and look at what is causing the problem with the swallowing function and then fix it. Versus just modify diets or place people on peg tubes. You know, Medicare is really looking for some options of can we do functional rehabilitation to get the swallow better. And I think once we slide into that role and start recognizing that it's a neuromuscular function, we need to be able to measure our exercise just like a physical therapist would measure the output of getting that their muscles stronger. We need to be able to do that as well, because these muscles are fast twitch muscles. They're very small. They require a lot of exercise. They get into disc atrophy. And if we can support a patient getting back to a more normal swallowing function, even if it's just better than it was, that's progress. And I think this device will allow us to show the benefit of what we're able to do through documentation. And you know, whether it's this biofeedback or something else, I think gone are the days of us standing beside the patient saying, hey, I think you're swallowing good. Feels like a lot of laryngeal elevation to me. You know, I don't feel like Medicare is going to accept that as we continue to advance. So I'm always looking for options to pass along as treatment options, because, you know, doing the evaluation is just the beginning for a patient. It's just the very beginning of their journey. And so, you know, we want to have the tools to be able to help you support your patient through the rest of that journey. And so we're getting more involved on that treatment side of how to pull all this together. And if you can show this poster to someone, show them that you are the exercise physiologist of swallowing, I think they'll start to view us a little differently and start to recognize our value in treating and managing dysphagia, just like Medicare has in their reimbursement, especially when we know that the percentage of patients who are affected is so high, especially in the SNF. So hopefully, you know, this is something that excites you guys as well. We'll be doing some work on our clinics with these devices. Some of you will be, you know, some of your patients will be selected. We're in the talks with some corporate entities right now to try to get them on board with allowing us to pass this through as a trial to some of the patients that we're seeing. And of course, you can contact True Angle and get a mobility for yourself if you're working in home healthcare. I would have one of these in my pocket if I was in home healthcare. I mean, I just saw it and I said, I got to have one of these on the clinic. I need to know how we can help a patient. But it's affordable, accessible, and hopefully adds value to what to the output you're getting for your patient or the outcomes. Does anybody have any questions? Well, I just want to thank you guys for coming today. I really appreciate you spending your Saturday afternoon with us. Hopefully, you know, you had fun having a mocktail or a cocktail, whatever floats your boat, coffee. whatever you like, and that not only were you sipping away on your drinks, but you were also learning something. So that was the goal. And we just appreciate all of you as our colleagues, and you know, we're all ready to get back to normal, and hopefully with the vaccinations coming, we're starting to feel that just a little bit. So we're excited to spend our time with y'all and can't wait to where we can actually gather all together.
Yeah.
So have a wonderful Saturday night. Is there any other housekeeping?
Just housekeeping, if you guys had joined us late, I did email out the packets. If for whatever reason you didn't get it, you're welcome to email me. My email's in the chat. If you joined us on Facebook Live, thank you so much. It was a non-pre-registered class. You can join us if you wanted to, but please make sure that I have your email address. I want to ensure that you're going to be receiving your CE credit. If you guys lose them for any reason, call our office, email me, text me, I will resend it to you. We want to make sure that you guys are getting the credit that you for the CE course.
Yes, and remember, Tisha is an ASHA approved sponsor. However, they do not show up on your ASHA registry, so they don't have a communication with them. You do have to physically have your certificate to submit, but it does count. So I just want to be sure you don't lose that certificate, and if you do, reach out to Stephanie or I. We're happy to help you re-secure that certificate. Yeah, y'all have a wonderful Saturday night, and thank you so much. If there's any questions, please leave them in chat, and we'll try to get back with everyone who has any questions or ideas. If you want to hear another topic, please include that. I know some people were requesting that we do an ethics, like a coffee talk for ethical discussion. I think it's a great idea. So look for that coming up, probably summer.
Yeah, and then a PDGM, which is very similar to the PDPM. If you're unfamiliar with PDGM, that's more related to home health. So I have been doing some research and trying to get some things together for that. So again, that'll probably be something that'll coming out like over the next 6 months, or so. We'll hang out a little bit longer in our, we'll hang out a little bit longer here on Zoom. If you have any questions, and just, we're happy to just answer anything. We'll be here probably for about another 15 minutes, as long as you guys want to talk to us.
Yeah, absolutely.
Or, and it doesn't have to be related to dysphagia. You're welcome to just chat with us. We miss seeing everybody. We're glad you all joined us. So
Yeah, it's been a
thank you
long
so
year
much.
for all of us. So thank you again.
Thank you,
Hey
guys.
guys, can you hear me?
Hey.
It's Nisha.
Yeah, I can hear you. How are you? Is it LaShawn?
I'm good. I got a late start because
It's Nisha.
yes,
Hey.
I managed to get in. I'm okay. I'm real good. Thanks. I'm retiring. Well, not really. I'm semi-retiring.
Well, you know, you've been a great colleague for many, 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 many years, and I'm so sorry I didn't get down to San Antonio this year. I couldn't believe a pandemic kept us away from San
I know,
Antonio.
terrible. Well, yeah, I'll still be around. I probably
Oh, that's great.
won't be on the clinics very much because I'm doing PRN mostly, and but anyway, I because I did get in late, were there any new coding, were there any new codes added with COVID that I missed?
Well, we didn't have that on here so far. They only have the iCode linking. I got the newsletter from Medicare. They are currently in an open period for adding more codes. So I do think it's coming.
Okay,
I have not seen that come out yet, but if I do get them on my email or they actually add them, then yes, I can email those out to you guys and certainly send them to you.
okay. And Stephanie, I probably will have to send you a note on your email because my email, I did not get the link. It wasn't, my student was watching, my grad student, and she sent me the link on my phone. So I'm actually able to watch most of it on the phone. So.
Okay, great.
Oh, that's great, Nisha.
Yeah, I had a couple people, I don't know if something was going on with my email. I had to resend it a couple of times. I have to get my IT guy to look at that. So I
Yeah, no,
if anybody out there watched this, like I did not miss you. I promise I sent out the email. I'm not really sure what happened. So I hope you joined us on. I was trying to get to everybody who told me that they
Oh
were
yeah,
having
it's
problems.
okay. I'll just send you something so that you have my return email. So that'll work out just fine. Okay,
Absolutely.
well,
I'm excited to get your CE credit. Absolutely.
I really appreciate your doing this again. I know I told several therapists to watch because I
Oh, great, Nisha, thank you.
help. So I appreciate it a lot. It made a lot of difference for my coding this year.
Oh,
That's good to
yay,
hear.
that's wonderful. Thank
Yeah,
you,
so-
Nisha, that
so,
means a lot.
Yeah, I appreciate all your time and effort in doing.
Absolutely. Well, we've had a great time doing it. You know, we were hitting the trail last March and then, I mean, we literally drove to the valley, came back. I think I went, on what, you know, my one vacation a year that I usually go on, skiing, and I came back from the mountain, they shut everything down, and we were in the middle of a pandemic. So we couldn't believe that we couldn't carry it around, you know, further than we wanted to. It took us a little longer. I think we did a Zoom, we got organized and did a Zoom in May, because we literally just shifted from PDPM to protecting patients, protecting our staff, trying to get enough PPE, getting our COVID policies in place like all of you guys. And that was a couple of months of just trying to, that was a
Right.
long couple of months. I know you guys have had a long,
Right.
long year.
Long year.
Because on our end, we don't even walk into the building except just to get the patient, and it was just a massive effort to protect everybody. So I can't
Yes.
imagine what you guys were dealing with. But we're
Well-
on the other side, I feel like we're getting to the other side of it. I know that the last thing I read was 16 million vaccines have been giving out, or doses of vaccines in Texas. You know, I don't know how Indiana, Ohio, and Kentucky, I just get a little more news about Texas, but, you know, we're just grateful of all the people that work so hard to take care of these little patients, and it affected our patients more than anybody because they were the highest risk.
Absolutely.
So
Well,
you guys
I-
did a great job. I don't know how y'all did it, because we felt like we were drowning over here for a couple of months, or at least 8 months.
I think everyone felt that way under their own circumstances. It was difficult for, and believe me, I thought about retiring sooner.
You didn't know the pandemic was gonna, you know, push that through. Well, you know, and when we're all helpers, I mean, that's what we do. That's typically why we get into speech pathology. We like to help patients, and you know, that we just had to shift our mission a little bit and start prioritizing and triaging and figuring out still how to help people. And you know,
Yeah.
I mean, we still saw patients who had trouble swallowing. You had to weigh out, is COVID risk worse or is the swallowing risk worse? You know, so it was kind of during that period, we saw the patients who had the most difficulty. So that was pretty tough
Yeah.
clinically, because we were seeing just the patients who triaged in at a really high level. And
Yes.
our clinical team kind of felt like, gosh, we are seeing all these patients have so many problems. We're not seeing anybody who's doing better. And that's hard as a clinician when you're only seeing the worst problems. You start
Exactly.
thinking everything's, you know, everybody's got a problem, when really it's just the ones you're seeing.
Right.
So that was hard, but look, we appreciated you guys. We've all worked together. We've talked to most of you. It's been interesting navigating this, you know, as a care team, but people still need care. That's the reality.
Exactly. Well, I, again, thank you so much for all your effort in doing this. I appreciate it, and I will look forward to the ethics.
Yeah, I can't wait to see you, Nisha. It'll be great to
Okay.
see you.
All
All
right.
right, take
Guys,
care.
bye.
Thanks for joining us.
Thank you.
Anybody else have anything they want to share or add or vent, or glad that things are getting a little better? Hopefully they are for all of you.
Thank y'all.
Hey, Sean, you still work at Lakeway, right?
For now, I guess. Yeah.
No, well, Jessica's my really good friend. She's in the OTs out
Oh
there.
yeah, Jessica.
Yeah.
She's great. She's been PRNing for us for quite some time now. Maybe a month or so.
Yeah. I was taught her she's an honorary speech pathologist.
Yeah, Jessica's great.
We've been trying
to train her to be a speech pathologist for a while.
Yeah, it's
She's
been
the
a
one
pleasure
that
getting to
cues
work
us
with
in
her.
about all this GG, like what we need to know, you know, so that's a good friend.
Yeah, she used to be a rehab manager for a
Yeah.
while.
She gives us those cues. How's Lakeway doing? Are y'all recovering? Oh, I think he's out.
What was
LaShawn, you
about
good? Oh, you're still there. Is Lakeway doing good? I mean, are you guys getting back to a little more normal out there in Austin?
Sort of. There's a possibility that the building may be sold, but
That's what I
that's
heard.
kinda up in the air still right now.
I'm gonna tell you, these nursing home administrators, corporate entities. I mean, it has been a struggle for all
Yeah,
of
I mean,
them.
the PPE alone for that last year was crazy amount of money. I mean, masks at one point were like $4 to $7 a pop when they were price gouging. You know, so you're talking
Yeah.
about hundreds and hundreds of thousands of dollars. So, you know, my understanding was Brookdale probably took a huge hit. So,
Yeah, well, I mean, everybody, you know, it's just kind of trying to stay afloat, keep your head above water. You know, it's tough for everybody. It's just kind of everybody problem, you know.
yeah,
For the
I
business
mean, we've been
owners,
doing
the-
awesome this year so far. So
Oh, that's great.
it's a good turn.
Well, you know, that's all I can do is turn the corner and try to, you know, go up.
But I did get a new puppy yesterday. Does anyone want to see it?
Yes.
Okay.
Let's see your puppy. Who doesn't love a puppy? Oh my goodness.
This
Yes.
is my new puppy. This is
What's
Koi.
his name?
Oh my God, beautiful.
Oh my God, I love him. Does he have blue eyes?
He has one blue eye and one's like a marble color. It's like brown and
Oh
blue.
my gosh. Okay, there you're on this. I have 3 screens, so. Wow, what did you name them?
It's Koi.
Koi, that's so cute. Oh my gosh. So
He's
did
been
you
my
have a
partner
dog
for
before,
the
or is
video
this
or the
like-
presentation. He's getting a little
Because
wiggly
I-
though. What's that?
Did you have a dog before that, or is this just?
Yeah, I have a husky Malamute too.
Okay.
So
You need a
he's
friend, huh?
he's a pure husky.
Oh, that's great.
Beautiful.
So cute. Oh my goodness.
Yeah.
Love it.
Thank you guys for letting me share.
Oh,
Yeah,
that's always
fun.
fun. Those are the fun, cuddly little parts of life that make it worth it. That's
Yeah,
great.
he's certainly been a joyous thing for us right now. for sure.
Oh, that's awesome. Yeah, anything that you can do to bring a little joy in. It's been a long, depressing year for everybody. That's why we said, me and Stephanie were sitting around and we're like, what can we do for a conference? And she's like, you know, probably everybody's just drinking themselves to death because this is so depressing. I said, well, what if we learn something while we drink? Wouldn't that be a great thing? And she said, yeah, that'd be awesome.
No, I mean, you guys have certainly given me I'm going to go back to the MDS and talk to the doctors. If I can get them on board with that comorbidity, that would certainly help with reimbursement. That's for sure.
Well, and you know, when we do the swallow study for you, our physicians are pretty open to helping make that recommendation. So like if you text LaShawn or text Sarah and let them know that you think this is a patient who may qualify based on what they see on the swallow study, then it's easy for us to link those together for you so you have a little bit stronger case.
Yeah, absolutely.
Yeah,
Thank you,
because
guys.
then you're supported in multiple care teams and, you know, sometimes when people see that from another physician, they're a little more willing to accept that level of information.
Yeah, I feel like, you know, in speech therapy, you know, how often do we get, I mean, I would say like my experience in SNF is like probably about 75% of the patients that came into my SNF did not have an I code at all. Like, no, there's no way for me to link anything to their dysphagia. But that was the day whenever, you know, those are the days when it didn't matter. You could treat on an R code and at a high level. But now it matters. And so, you know, we were just trying to figure out, like, knowing what I knew in SNF and Piper knew in SNF, we're like, what can we do to help SLPs get these ICOD linkings? OTs and PTs have it pretty easy. It all links everything together. They have so many diagnoses.
Yeah, and we were like, nobody called us about this I-code linking to write this, you know, they should have included a speech pathologist. So we're excited to hear that Medicare's opening up some of that now to look for more I-codes.
Yeah, I think PDPM, there's good stuff about it and there's obviously terrible stuff about it. I mean, I guess it's the same way with how it used to be with rugs, I suppose.
Yeah,
Except
I
we're
mean,
more
it's
in
the
the
same
driver's
thing.
seat for rugs. So I guess it's been somewhat of a net negative as a therapist anyways.
Yes, ICODE linking that's a great question. ICODE linking is the same concept for speech and language, right? You know, you have to have an ICODE, you have to have a medical diagnosis that can bring that all together. So, if you have a patient that's coming in with some speech and language difficulties, I mean, there has to be something neurological that's going on. I mean, these are patients that at higher level of function, we're not having that. So it's the same concept. I know we didn't really focus on that because we're really dysphagia heavy, but that is correct.
Yeah, whenever our therapists call us on the van and we're going to, log on and look at a study or troubleshoot with them recommendations, usually, they want to tell us all the details about what happened during the study. And the first question that you'll, and some of our clinicians who work on the vans can tell you, the first question we always ask is, what's their primary diagnosis? We always say, what's their primary diagnosis? What's medically going on with this patient? We want to know how to tailor that to that patient. So I think that's really the key here is we were doing that before PDPM was cool. We were doing that even under the RUG system. We wanted to know what's going to be helpful to this patient in this situation with these particular diagnoses, with this level of cognition. And then we can tell you how to interpret the SWALLOW study and what's going to be relevant for that patient for recommendations. If we don't have that information, Stephanie and I feel like if we just know the results of the SWALLOW study, like if they aspirated, if they had residue, if they had an oral hold, we don't have enough information to make appropriate recommendations for that particular patient. And that's how all of our clinicians are trained, and what they typically, follow is a SWALLOW study may look the same, but one may be on a patient who had an acute stroke, global aphasia, and one may have had an acute stroke and they have just a little bit of right-sided weakness and no problem swallowing and can communicate fine and have a little bit of a slurred speech. So we're going to handle those recommendations differently, even if the SWALLOW study looks the same. So it's kind of a global approach to patient care.
See, I saw a couple of people pop in. Were you guys in earlier? I hope we sent you the right time and everything. Hey, Dave, had a couple of people leaving.
Well, thank you, ladies. I just wanted to say hi. It's LaShawn.
Hi,
It's good to hear from you.
Good to hear you.
Doing okay out there?
Yeah, doing good.
Good. Rachel, are you there? Is this Rachel Tilson? It just says Rachel.
Arrived late. Is the presentation recorded? Yeah, it is recorded. I can send that to you if you'd like. I'm happy to do that via email. It's okay. I know I've had a couple people kind of arriving late, so we do have the content if you want me to share that with you. I arrived to about 4:45. Okay, I think you got most of it. Do you want us to go over anything specifically? You probably got most of the content that we were kind of going for.
If y'all have any questions, you can certainly call the office or email us, or if there's a particular patient or a particular situation that comes up. Stephanie and I have a busy couple of weeks, but we're normally in the office. And so if they can't, they'll take a message if we're not here over the next 2 weeks. We're training a clinician, but if we're not here for any reason, we'll get back with you. I mean, we still come in at the end of the day and return the phone calls, and we can call you. If we can call you on your cell phone, that's always great, because we can call you after hours if it's a little longer day for us on those days.
Yeah, my cell phone's on there, and if you really need something fairly urgently, everybody knows how to get a hold of Piper and I from the office. So
yeah, and they all have our cell phones, so they'll call us. They'll give it to you, let you call us.
Yeah, people call us all the time,
Yeah.
and they're not even related to hey, I need a SWALLOW study. They're just wanting to collaborate on something. So
we're also consultants, so that's how we view ourselves. It's not just doing the evaluation, but we're there to support you guys as part of the care team. So if there's something you don't know and you think we can help, we're certainly happy to help. If we can't help, we'll find somebody who can help you and connect that dot. This is what we love to do, and we see all of you guys as our colleagues, and y'all really help us do a better job of taking care of patients, because we need that information to do that on the front end. What's going on with this patient, and we do value what you're seeing in the facility versus what we're able to see in about 20 or 30 minutes, 15 during the pandemic, because we were trying to limit face-to-face contact. But now we're able to spend a little more time, so that's the good part as well. Anybody else have any questions or ideas? Anything going on?
I just wanted to say thank you again to both of you, and yeah, just really appreciate all your time and insight and support. So I hope you have a great rest of the weekend. I know you've got busy weeks ahead. I hope it goes well.
Thank you so much for your time.
Yeah,
and
don't
joining
give
us.
up on us. We know sometimes we're a little delayed, but it's just
No, my
patient
goodness,
care
you guys are doing
related,
so
and
much.
just keep reaching out, and we're trying to tie all this together hopefully by the end of May, so we can really move forward with that. And we
Yeah, of
appreciate
course.
you guys. We're super excited. We get a lot of excitement, especially from our team who provides clinical care on the van, saying, hey, this is something I could really see adding value and passing along to the speech pathologist just from a baseline of what we're doing. So I think it's just so cool what y'all developed. So I'm
Oh,
excited to get my hands more into that.
Yeah, me too. We'll get in touch once things chill for you a little bit, and we're excited about it.
Sounds great. Thank you, Gabby. Thank you, Evelyn.
Thank
Appreciate it.
you.
Y'all have a great rest of the weekend.